This is a special episode of the Immunology Podcast, Immunology 2023, Day 2. Hey everyone, this is Dr. Jason Goldsmith and Dr. Brenda Rowd. Welcome back to Immunology Podcast, where we have conversations with immunologists. Today we're back with another special episode to discuss highlights from the Immunology 2023 annual meeting taking place here in Washington, D.C. If you're at the meeting, be sure to drop by the Immunology Podcast booth in the exhibit hall to meet the team and win some prizes. You can also chat with us about your research and find out how you could be featured in a future episode of the podcast, or take a selfie with us, as you're probably seeing on our social media. Today we'll be discussing some of the most interesting research we've seen presented over the past 24 hours at the meeting. So if you were in another session and weren't able to attend the meeting, we've got you covered. We're going to be kicking things off in just a moment, but before we get to that,
join us at STEMCELL Technologies' upcoming workshop presented at Immunology 2023, where you can learn about new tools to optimize your B-cell research. Dr. Anthea Nice and Dr. Hitesh Arora will talk about feeder and serum-free expansion systems to obtain high yields of human and mouse B-cells for your downstream applications. The workshop will take place on Sunday, May 14th at 11:15 a.m. in the Exhibitor Hall Workshop Room 1. For more information on STEMCELL Technologies workshops or to learn more, visit STEMCELL Technologies at booth number 4011 or learn more at stemcell.com/AAI.
all right, we're at day 2 here.
Oh, yeah. How are you liking it so far, Jason?
It's good. It's good. It's a nice change of pace from some clinical conferences.
Yeah, right?
Get to nerd out a little more. I enjoy it.
For sure. There's a lot of place for nerding out in here. So many talks, so many smart people showcasing their research. That's great. It's really nice. And also yesterday after we recorded, we had the presentation for Mark Davis, which I also thought was very nice. It was so cool to see all his pictures from his early time, and just, I don't know, it's nice to see those things, don't you think?
Yes, I particularly enjoyed his review that he was presenting from his feedback from a student. Yeah, way back when it was.
It was not a very good review, ladies and gentlemen. But
it would earn an E. Yeah, it earned you that explicit E on a podcast, but it was hilarious, and I think he took it tongue in cheek, so that's good.
Yeah, that was good, and I like that his approach to chemistry. Also, some things cannot be. I don't think we're allowed to say. But
chemistry is the central science, and it is a crucible of purity.
Yeah, and no BS discipline, apparently. Was funny. So yeah, so very nice. And today, so why don't you start off with some of the talks you went on?
All right.
Today?
Well, I'll do it with the first symposium, and I'll kick it back to you. So I went to Major Symposia A, peripheral neuroimmune interactions. But we had a couple guests from the podcast who are presenting again. So we have Daniel Musida. He was talking about the role of neurons after infection, and he showed that so you have increased colonic transport times after salmonella infection. And they were showing that you had neuronal damage in this case, but that hemolymph infection led to tolerance and lack and kept the neurons intact. So a hemolymph infection ahead of a salmonella infection prevented the neurons in your gut from dying from the salmonella. They demonstrated it was progenitor neurons, and that there's a certain cluster of these progenitors that are sensitive to the microbiota using antibiotic and FMT studies. And then they did some cycling and lineage tracing to really demonstrate that, like, getting the bacteria back kept the center going. So there's this progenitor neuron group that's responsive, but then they're going to be tuned by the hemolymph infection against the salmonella infection not to die. So I thought that was interesting. The next one from a former guest, Caroline Sokol, also was talking about allergic responses, talked a little about the skin like we had with her. Kind of some stuff she dropped into a little more was that allergen-induced itch requires gamma delta T cells, and that there are microbial factors and skin allergen exposure combined help lead to who has allergies. And so she also demonstrated in some of the newer work that sensory neurons are what initiate the allergic immune response. And if you chemically deplete the sensory neurons, you don't have an allergic immune response. So the nerves are in charge of your immune system's allergies.
Oh my God. Well, yeah, we've covered this in the podcast before, and I'm always so mind blown by these concepts.
So then a couple other people. We had Esther Borges-Florsheim now have their own lab, and they looked at how mast cell lipid mediators like leukotrienes promote food aversion. Essentially, kids will avoid eating things they're allergic to, even if the parents don't know it. that they have an allergy, and this is also seen in mice with sensitization studies. And you can give them all the sugar you want as an additive, they still won't avoid it. It's not taste dependent, but they haven't established if it's smell dependent or not. And they found that IgE antibodies, so depleting IgE removes avoidance. So IgE is usually viewed as a bad actor in an allergy, but it's actually causing protection and avoidance mechanisms for allergens. And they showed that MYC1, known as GDF15 now, promotes avoidance, and that is dependent on IgE, and it's due to expression in the duodenum.
Wow. The complexity is baffling.
And then we had a straight-up neuroscientist come in, not neurologist, neuroscientist, Jessica Osterhout, talking about the neural circuits of sickness behavior and fever. And fever generation. It used to be thought that prostaglandin sensing led to thermoregulatory neurons driving things. That's why things like Tylenol and ibuprofen and aspirin reduce fever. But there's more than that. It doesn't look at cytokines. And it was a little hard to follow just from where I sat, and so I think some basal assumptions were being made that I couldn't quite track about neuroanatomy. But she was able to trace some of this to specific neurons, then use drug-inducible mice, for receptor-induced mice, so those dread receptors, I believe, to then do some stimulation and trace it to a neuronal circuit and show that cytokines also drive this pathway. It is not just Tylenol, not just prostaglandins, which explains why prostaglandin blockade alone doesn't present fever in patients all the time.
Okay. Very interesting. I guess a lot of implications for therapy, especially if patients don't respond to Tylenol and
Ibuprofen.
Is that ibuprofen, that right? Is ibuprofen?
Yeah. So then there's the IL-1 and IL-6 inhibitors, which are used for cytokine storm now, which is like fever on steroids, and so that may be also why there's some effect there we see.
Okay.
Obviously, much bigger cascade in those cases, but it kind of lines up as a similar story. All right, so what'd you get from that? Was like the first half of my day. It was a very long symposium.
It's a very busy day. I have to say mine were a little bit smaller. So I went to the cellular therapy session in the morning, and I had to say my highlights were there was an interesting talk from Emily Simon Rav from the University of Texas MD Anderson Center, in which they are using CAR NK cells to target CD70 positive osteosarcoma. And I think, using NKs for therapy or using CARs is not something necessarily new, but I think they were looking a lot into really understanding the expression of CD70, which is expressed in osteosarcoma cells, but it's very heterogeneous. And although it has very low expression on tissue, which makes it a potential target for CAR therapy, it is a problem when you have low expression. Then that usually becomes problematic when targeting with CAR constructs. But they show that their CD70 CAR NK cells are cytotoxic against osteosarcoma that express low CD70, so that's quite important. And they even have this model in which they have 3 spheroids, because osteosarcoma is bone cancer. So one of the complications is that it's actually hard because you need to get into the bone. So that's an added level of difficulty for CAR T cells or CAR NK cells in this case to find their target. So they made 3 spheroids, and they show that they also are really effective at killing CD70 positive cells in this structure. And they show that they can produce cytokines. And also, it was interesting for me because I don't work a lot of NK cells, but and this is probably one of the limitations of NK therapy, is that they seem to have limited persistence, more limited than T cells. So I wonder what exactly is like the approach when you're thinking of NK therapies. Are you thinking of like cells that don't have a really long survival, like because CAR T cells will home in lymph nodes and will persist for years, but doesn't seem to be the case for NK cells. I'm always curious of how do you accept that, or how do you work around that limitation? So they didn't have a solution, but is another way. I think NK cells can be very promising cells for therapy.
What about for debulking or things? So sometimes you just need to get the tumor a lot smaller.
That's true, yeah.
Especially like maybe not sarcomas, but even then, so you don't have to rip out as much bone, but things around nerves, right? Like if it's impinging on a nerve for some of these mesoderm cancers, like I can make it smaller without radiationing anyone to death, and then I can excise it when it's not entrapping the nerve.
Yeah, for sure. Or for example, at my old institute, they was super. They had this clinical trial with immunotherapy against head and neck cancer, and it was so dramatic that some of the tumors they responded. They didn't know it was not a complete response, so the tumors did not disappear, but they became small enough that they didn't have to cut the half of the face of the poor patient off in order to remove the tumor. So that was already such a huge improvement.
Right, they do that now with chemo and stuff, but it's obviously much more toxic, and so it's going to be a much more precision way of doing that, and then coming in with chemo and radiation and surgery, and then finishing it off.
Yeah. So, on another CAR talk, in this case CD8 CAR T cells, it was actually two talks from the same lab, from the lab of Terry Fry at University of Colorado. So first we had Cole de Gaulier. So the talk was titled "Antigen Experience History Directs Distinct Functional States of CD8 CAR T Cells," and they are thinking of the problem of leukemia and CD22 targeting CAR T cells. And in this case, these CAR T cells do have issues with CD22 low expression. So again, low antigen. So often is the case that CAR T cells don't work very well. And it's interesting because then they thought they were comparing two different ways of making CARs, whether you have mice that were previously vaccinated. I have to admit I missed the detail of how they make the CARs, like what was the vaccination against, but the idea that you are transducing with your CAR construct a population of T cells that are memory cells that have been activated, and they're kind of not completely a naive population. And then they compare that with just T cells that are just fresh from naive mice. And they see that they have some fundamental differences in how they work, and the kind of responses that they mediate. They see also epigenetic differences as expected between what it would be a memory population and a naive population. But they see is basically this memory derived CAR T cells are better at targeting the low antigen leukemia cells. They're kind of more primed and they're faster at attacking the tumors. They have this kind of enhanced cytotoxicity, but in the end, I think they have some issues with persistence. So they're not perfect models, but they do seem to be better prepared to attack low antigen expressing tumors and to have like a first wave of effector function. So in the end, it was if the antigen was expressed at normal levels, like on a situation in which you had higher antigen expression levels, then it was not so beneficial, specifically when you had the situation of low expression of your target in the leukemia cells. But what I didn't understand is the vaccine. I don't think the vaccine had to do with the final antigen. It was just about activating the cells, because the specificity anyway is given by the CAR. It's just about making the cells activated and make them memory. So yeah, and then what else? Also that session, we had some CAR T cells that were expressing IL-33 and superkine IL-22 that showed very interesting phenotype. They saw they was this CAR T cells is from Dartmouth, Asma Mohammed. And the interesting thing about her talk, I think, was the fact that they see that they wanted to try to make tissue resident memory cells. So they wanted to make this CARs into tissue resident memory cells, and that was proving difficult. So they see that if they deplete CD4 cells before injecting the CARs, that actually helps the CAR this CAR construct with IL-2 and IL-33 production to kind of populate the tissues, and there's a higher percentage of tissue resident memory cells in skin. So I think it's they I don't think they was really clear why they think that's the case. I think she mentioned that maybe there's depletion of endogenous regulatory T cells. But I think I'm gonna go and check out her poster tomorrow at poster 326 to see a little bit more, because I like the idea, but I think I missed something. So, but it's interesting because now there also this nowadays these armored cars, I think they call them, the ones that are producing cytokines to support their function. They're also very interesting models sometimes. And then the last one of the day was from Menling Chen from Rutgers. And in this case, she was looking at the role of CD69. Again, it's another marker for residency, for tissue residency in T cells. Basically, she correlated the expression of CD69 negatively to CAR T cell expansion and function, basically. So they have a model of CAR T cells against a human cancer antigen, and they compare CARs with 41BB and CD28, which we know are two different co-stimulatory domains that are added to CARs for their function. And they identify a CD69 low population. And then this population is the one that correlates with CAR T cell expansion, and they express lower levels of what usually exhaustion markers, and they kind of conclude that CD69 is inhibiting proliferation in the tumor microenvironment, which would be this kind of tissue residence if you think the tumor is a tissue, and that CD69 knockout actually allows cells to accumulate more in a tumor microenvironment, and to have enhanced functionality. So they kind of suggest that CD69 is suppressing T cell proliferation and effector function in this particular model. So I think it's cool because CD69 is usually associated with tissue residency. So I thought it was a little bit kind of strange, but she had really nice data. So that was my morning. Oh wait, I know what I also think in the morning one more because that was cool. I'm talking about NK therapy for dogs. NK therapy, for dogs. I when I talk, I have to say it was a little bit out of my kind of my realm of knowledge, but it was cool that they treated dogs with cancer, with melanoma, with expanded NK cells, and it seemed to work. Some of the dogs really survive a lot more than usually expected. They normally get radiotherapy, and that you can basically expand these NK cells from bulk PBMCs. And I didn't quite understand why NK cells and why, if you can actually expand NK cells from bulk PBMCs in humans. But I thought it was cool that they were treating dogs with NK cells for cancer.
Not sure how I feel about that one. Just because the cost.
Yeah. I mean, they were also old dogs. Most of those dogs were over 10 years old.
What I mean is like the cost of a NK therapy. I mean, I guess people have the money, they can choose to do it.
Yeah, that's your dog. How much is your dog worth for you?
Probably not your mortgage.
Yeah, I guess this particular dogs were treated for free, probably.
Oh, I'm sure, right? I'm just thinking about like the market for that, and I wonder like what they would do. Yeah,
I don't know.
So I'm probably being too practical for all the pet owners out there,
probably.
But that's also very expensive.
Yeah.
All right, so afternoon, I went to Society for Mucosal Immunology talk. There were a couple there I really wanted to talk about that I got excited with. It's a microbiome land. So first we had Gretchen Dahl, and she talked about some mechanisms, some stuff I knew, but like went in deep dive on it, which is that epithelial cells at baseline are not very sensitive to TLR4, TLR5 signaling, which makes sense. You would not want your intestinal epithelial cells flipping around with LPS because they would just flip out all the time. But they do know that the crypts, the stem cells themselves, are sensitive to it. But if you then go and look at the microbial community, the crypt itself, where the stem cells are not colonized very much. And so they start doing the studies here where during damage you see bacterial infiltration, and that can then cause that LPS signaling to then induce regenerative pathways because, oh my God, there's bacteria here, we need to do something. So they kind of deep dive a little bit more of that pathway it's already known. But then they also talk about how a specific type of E. coli protects from DSS colitis in a T-cell dependent manner. And this through CD4 cells, doing all these depletion studies. And this works because it's priming these cells to induce regeneration early. So the E. coli can get to the crypt at baseline and prime them. So when you stimulate those stem cells, when you hit it with DSS, which causes a wipeout of the epithelium, they're immediately primed to regenerate. So that was neat. Then we had Kathleen Koop, who looked at the early life protection in the intestine. So necrotizing enterocolitis, all these terrible diseases that happen to babies. And she established some pretty cool stuff. So one, she has an asynchronous cross-fostering system where you can take pups from different moms at different times and then transfer them so that, like, you can, have two moms, and one mom being weaning or, feeding via breast milk some pups, and you move other ones in later on, because what they found is that the amount of EGF in breast milk wanes over time when the mother when she starts breastfeeding. It decreases over time. So day 1 higher than day 20 of breastfeeding, so on and so forth. And so you can do these cross systems to, like, bring a mouse in at a certain point and see the effects of differential EGF in the breast milk downstream. What's interesting, though, is that this EGF decreases over time, and it also decreases in the stool over time. And she found that E. coli translates across the gut barrier via goblet cells in the absence of EGF. And that the gap formation, the lack of junctions between the E. coli, or between the barrier, is driven by the lack of EGF. So EGF strengthens the junctions between cells, and particularly goblet cells, very early in life to prevent bacterial translocation, and that when you ablate this, you get more bacterial translocation, thus disease in very young babies. Secondly, we know that, like, when there's certain conditions going on, antibiotics can increase the outcomes of having a successful pregnancy and delivery later in life. But this is with penicillins, and they've noticed a lack of the same effect with other classes. You're allergic to penicillins, you switch to something else called cephalosporins, which are a cousin, but the allergies don't translate necessarily. And so that's the first thing you go to. And they were able to establish that the IgA levels in breast milk are reduced uniquely by cephalosporins. It doesn't affect the dames. It decreases IgA, notably specifically to E. coli. And so you lose that protective defense against E. coli. And they also were able to establish in the same talk, looking at some other things, that maternal IgA limits group B strep. So that the amount of group B strep that transmits into the baby is based on the maternal IgA, or IgA in this case. So just some interesting mechanisms linking breast milk, growth factors in it, downstream enteric pathology.
All right.
So that was a good chunk of my afternoon. Saw some posters. Shout out to a couple of groups at South Carolina. I couldn't catch their name, but they had some really cool posters. They actually, it was their very first conference.
Oh.
They didn't have any cards or anything.
Oh.
So, but they had some really cool studies on inflammatory bowel disease and neuroimmunology in relation to depression.
Oh, wow. Okay.
So that was really neat to see. Some cool stuff.
All right. What's the takeaway message from them?
Takeaway is that there's this receptor called the aryl hydrocarbon receptor, which is a tryptophan receptor, and it modulates the depressive response in mice, and when IBD disrupts this pathway and that's part of what causes the more depressed state in patients, which we know have IBD, but then the mouse models. And then other work I've seen even recently at another conference showed that it's transmissible. So if you take IBD or UC stool with ulcerative colitis, from ulcerative colitis patients, and put it into mice or rats, they develop anxiety and depression due to decreased aryl hydrocarbon receptor activation.
Wow. I mean, gosh, that's the implications of such studies are just mind-blowing.
Well, clinically, it's very well established people with IBD have depression even above and beyond their level of morbidity. Like, you seem like it's a sucky disease, so you're going to be more depressed, but beyond that, there's high levels of depression than you would even anticipate necessarily from that.
Gosh, your bacteria are giving you depression. All right. Talking about bacteria, but not depression. I just want to highlight, I went also to the NIAID symposium. And I'm just going to highlight the talk from Barbara Rehermann, in which she also works. So she works at the NIH, at the, I think is National Institute for this diabetes and something and kidney at
digestive disease, diabetes,
yes,
diabetes and kidney disease,
That's
NIDDK, land of GI goodness.
That's the one. So I just thought it was very interesting because she was talking about whitening of mice. which is basically transferring microbiota from wild mice into the lab to study into an inbred strain, so that you get the genetic part kind of controlled. And so basically, she made the point, I think we all know, that laboratory mice are very clean, and they're basically a completely different meta-organism compared to wild mice from the wild. And so they no they see them themselves. Is they brought mice from outside, they look at their feces, and they compare the composition of the microbiomes, completely different. And so what they do in order to work with mice, with genetically identical mice in the lab, is to transfer the microbiota. What they do is they take wild female mice and they transfer like black six embryos to these mice. They do this pseudo pregnancy thing, and then they transfer the embryos. So you get black six mice being born to wild mothers, and then they kind of acquire the microbiome from that, and very early on in life. So that really seems to be the best way to model the wild microbiome acquisition. And unsurprisingly, they find a lot of differences with the regular laboratory mice. Of course, there's much more diverse microbiome. There are fungi, there are viruses, and this makes, of course, their life very complicated. They seem to have a completely different facility for these mice. They also were very concerned about whether, these mice would get contaminated from like the microbiome of like laboratory mice. So they kept them very separate. And this is not normal, good practice, I think, in general. And so there's also funny because they looked at which it would be kind of the stronger microbiome. They co-housed a wildling mouse, so a wild mouse with a wild microbiome, then a laboratory mouse with a pathogen-free microbiome, and then a germ-free mouse. And basically, what they see is that all of the mice end up converging on the microbiome of the wild type. So it completely overtakes both the germ-free, but also the specific pathogen-free mice. And I think she makes a really important point of how using this mice might be very important for some of the drawbacks of preclinical studies in mice. And she makes the case of a particular situation in which the use of an anti-CD28 monoclonal antibody in lab mice was shown to expand regulatory T cells and thus downregulate immune response. So it could be used for people with autoimmunity or with inflammation. And actually, when they tried that in humans, it was a disaster in the sense that it resulted in a cytokine storm in every patient that got it in the phase 1 trial. So really was a huge disconnect between the mouse study and the human study. And so they show that with these mice, in which you have these wildling mice, you actually see no increase in regulatory T cells if you inject them with anti-CD28 antibody, and you do see an increase in the release of cytokines, which makes it probably a better model for humans. And if the experiments had been done in this mice, probably humans would have never been tested with it. And also she made the point of, in the case of a high-fat diet, wildling mice gain less weight. This is kind of has been a known thing that if you feed laboratory mice with high-fat diet, they get fat and they get fatty liver, and it's terrible. But wildling mice gain less weight, and it does seem that this is because they have a higher energy expenditure, which apparently is mediated by a higher amount of brown fat and body temperature, and that is how the mice pick up less weight. So again, this seems to be important. These kind of things are probably closer to the human situation. So she just highlighted the importance of having these models, and I thought was very interesting. A food for thought.
Very interesting. I'm stuck on the how do you get the wild mice?
You just go to the fields and you put some mouse traps with some cheese in them. I don't know. She said, I think she said the student or the postdoc picked it from the fields in Maryland, something like that. So yeah, I think that was it for today. Oh, I also attended. We had a very interesting talk about science communication and discussing your research with in a public kind of a with press or with
A podcast host.
yeah, no, with journalists or how to broadcast your science and your science, how to engage in the scientific discussions. And that was Christina, our producer, was there also talking about how to bring your science to a podcast, which is what we do here. So it was very nice. We're very proud of her. So shout out to Christina, our producer. And I think it was very nice. But a lot of nice points made about how to interact with journalists, how to bring your point across, and how important it is for scientists in general to contribute to the public discourse.
All right. Well, with that, we'll be back in about 24 hours with another late-breaking episode.
Oh, yeah. So
this brings us to the end of day 2 of the Immunology 2023 conference and our second episode of this special edition. Don't forget to follow us on Twitter at @ImmunoPodcast to find out what we're up to at the meeting, and visit us at the Immunology Podcast booth on the exhibitor floor, where you can get a prize and find out how you could be featured in a future episode of the podcast. Check back here tomorrow for another episode recapping day 3 of the meeting. See you then.